Hello and welcome to your online lecture for the hip. I can't believe we made it here. We started in August and now we're here. We started with the foot, the toes, moved to the ankle, lower limb, went to the knee, and now we're at the hip. Our last stop is the pelvis, you guys, so we're almost there. So I guess that's kind of my encouragement to you guys is we're almost through the lower extremity. I hope by now that you have a really good grasp on what it means to assess the joints that we've already covered. We're moving into the hip joint, and so we'll break this lecture into two parts. The first part of this lecture, which we'll cover currently, is really just focusing on the hip anatomy, historical questions that you might ask, and inspection of the hip or observation. In the second part of this lecture series, we will dive deep into special tests that can be used to assess pathologies. And obviously, we're going to talk about the pathologies in that second part of the lecture. So I'm really looking forward to these two hip lectures. Did you guys know that the hip is the largest joint and one of the most stable joints in the body? So it's large and it's stable. And you combine those two together, it's the largest, most stable joint in the body. And one of the great things about the hip that we see most often in the clinical setting is that if it's injured or if it exhibits pathology, then typically it's going to be immediately perceptible. In other words, you're going to see it either in the patient's gait when they're walking or when they're running or when they sit to stand or stand to sit. So it's one of those joints where the injury is most often extremely obvious to the clinician. So I think that kind of makes us less anxious about learning about the hip, hopefully. So our first stop is going to be in the anatomy of the hip joint. What we know about the hip joint, and I'm sure you all know this, is that the hip joint is a multi-axial ball and socket joint that has crazy amounts of stability because of its deep articulation. Do you hear me? It's deep articulation with this anatomical structure here. This is the acetabulum of the pelvis. And we're going to talk about its unique relationship to the actual femoral head. So when we think about it, a ball and socket joint, essentially there has to be a convex structure and a concave structure, right? A concave structure to receive that rounded structure. Our humeral head is going to be the convex structure, and then our acetabulum is going to be that concave structure. So you can see that that ball is going to fit relatively well into that socket. And if it doesn't fit relatively well, then we have massive amounts of muscles surrounding that joint, which will then kind of create a suction cup and keep that femoral head in that acetabulum of the pelvis. Okay, so if we think about the hip joint, a lot of clinicians would call it the femoral acetabular joint, right? They don't just typically call it the hip joint. They sometimes will call it the coxofemoral joint, right? So it has a name like the tibial femoral joint, right? For the exam, you can put the hip joint and I will accept that. But again, what's important on this slide is that you're really seeing this convex structure that has an articulation with this concave structure, and that's what creates the ball and socket joint and creates a lot of the stability that we talk about within the actual hip joint itself. So when we think about this maximum stability, this is an actual gross anatomy model. So we can see this femoral head, right, which is extremely convex. We can also see the acetabular labrum, and we're going to talk about that on the next slide, I believe, so I'll save that for then. But we can see how that femoral head is just going to fit really snug within the acetabulum, right? Okay, so as we progress, we kind of can't talk about the hip joint without talking about the pelvis itself, right? The good thing is we have a whole entire lecture series dedicated to the pelvis. But I do want to spend a little bit of time here because the acetabulum, which is the concave structure which receives that femoral head, sits on or lives or exists on the actual ilium or pelvis of the patient, right? And so what we know about the acetabulum is that superiorly it's formed by the ilium. Posteriorly, it's formed by the ischium, right? Which, remember that ischial tuberosity is going to be the proximal attachment site to the actual hamstring muscles. And then anteriorly, it's going to be formed by that pubis bone, right? So again, for recap, we have this acetabulum, which is made up of 3 bones of the pelvis, right? So we kind of can't talk about the hip without talking about the pelvis for at least a quick few seconds. So again, just to review, superiorly it's formed by the ilium, posteriorly it's going to be formed by the ischium, and then anteriorly it's going to be made up of the pubic bone, right? But all in all, this C-shaped structure is what we call the acetabulum, and it's extremely important in terms of creating hip stability for the hip joint. As we progress, we can really spend more time talking about the acetabulum, but we already know that it's this concave structure. One of the interesting things to me about the acetabulum is that the cavity is actually deepened by this fibrocartilaginous collar, which is known as the labrum, you guys, clinically, okay? So the labrum is an extension of the acetabulum, which deepens that articulation, right? Does that sound familiar? Does it sound like other anatomical structures that we've already talked about, like the meniscus, for example, which also serve to deepen the articulation between two different bones? Yes, good. Okay, the head of the femur is hemispherical and fits completely into the concavity of that acetabulum. And again, it's covered by that articular cartilage. So let's just go there, right? When we think about the labrum or the articular cartilage, it's not your traditional labrum. Most often when we think about labrums, you're going to see that kind of labrum lay down within the ring. But in this particular case, the acetabulum is going to be covered by a hyaline cartilage, and this is very protectionary, right? Just think about the tibial-femoral joint and those condyles and how they get or suffer from arthritis, right? It's that hyaline cartilage wearing away. So what we know about the acetabulum is that it's lined with this hyaline cartilage, which is great. It's protectionary. It's going to prevent friction and rubbing of the femoral head against the acetabulum. But then the beautiful thing to me is the way in which this labrum, do you see it here? This labrum creates a crazy lip over the acetabulum. And so imagine that femoral head sitting within that acetabulum and then that lip just suctioning it in or sucking it in, right? So it's almost like it's a suction cup. It's one of the major resources that creates that maximum stability about the hip joint itself. And I really like this gross anatomy model because you can see how it looks like a lip. And now, does that labrum kind of extend into the acetabulum? Most certainly. But again, I want to show you guys something here, and we'll get to it in pathologies, but I think it's important to point out is, I don't know if you can see this articular defect here. So remember I said that acetabulum is lined by hyaline cartilage, and we can see that hyaline cartilage here. But do you see how we can actually see the bottom of the acetabulum? So this is a patient who probably has some sort of arthritic or degenerative changes happening, right? But again, back to that labrum, you guys, I don't know if you guys can appreciate this at all, but it suctions the femoral head and creates the stability. So a tear to the acetabulum could lead to increased instability at the hip joint. So bony wise, we've already talked about the distal part of the femur, right? We did that when we talked about the knee joint in particular, when we talked about the tibial femoral joint. So I'm not going to spend time there. I'm going to spend time a little bit talking about the shaft of the femur. What we know about the femur in general, you guys, is it's the largest bone in the human body. You all know that. I think I said it this summer in our lecture series, but it's the largest bone in the human body. One of the cool things that we know about the shaft is it begins to change its shape about mid-shaft. And so a lot of the stress fractures or full fractures that we'll see will most often happen in the mid shaft of the femur because it's where the bone is weakest. Again, we don't really most often see stress fractures or complete fractures, but if we do see a complete fracture, it is a medical emergency, and we'll talk about that in class and how to care for that in a lab situation. But as we progress more proximally, I want to talk about important anatomical structures. So we have the greater trochanter, which is certainly palpable, and we'll do that in lab. And then on the medial aspect of the femur, we have the lesser trochanter, and they get their names based on their size and also their position. So example, the greater trochanter is larger and it's more superior when we look at it comparatively to the lesser trochanter, which is extremely small and inferior. So those two bones will become important, but palpable wise, you'll need to know how to palpate that greater trochanter. Next, we have the neck of the femur. The neck of the femur is one of the most commonly fractured sites when we look at elderly patients and when we look at those patients that are malnourished or suffer from some type of disordered eating or eating disorders, right? Most often this bone becomes extremely weak because it's changing its shape, and it's becoming the head of the femur, right? So oftentimes we'll see stress fractures in our cross-country runners, in our gymnasts, most often, or in our elderly patients. So those above the age of 50 or greater, right? And so if you're a physical therapist, when you have that slip and fall, most often with an elderly patient, most often what fractures is the neck of the femur. And then finally, what we have is the head of the femur. And the head of the femur is extremely important, again, because it's going to articulate with the acetabulum. And it's what's responsible for creating those osteokinematic motions, right? Those large, gross movement motions at the hip joint. So as we progress, let's go ahead and talk a little bit more about the bony nature of the hip. In general, we have the pubic symphysis, which it represents the articulation of both pubic bones on each side of the pelvis. So we have a right ilium, we have a left ilium. Where those two bones come together anteriorly, we call that the pubic symphysis. And we'll spend more time on this in the pelvis. So if I feel like I'm blowing through this, it's okay. For the purpose of the exam, you won't need to know pubic symphysis, at least for the hip, or the sacroiliac joint. But the sacroiliac joint is the point in which the pelvis comes together, the two pelvi come together and articulate posteriorly. Then we have the coxofemoral joint, another name for hip joint, probably what you see in your textbook, I think. Some spell it coxo and some spell it coxa. So you may see both forms or spellings for the hip joint, right? And then we have the ramus. But ultimately, you guys, what I'm saying for now in this particular lecture, in this particular section, we need to focus on the following. We need to focus on the acetabulum, which again is comprised of 3 different bones of the ilium, or the pelvis. It's the ischium posterior, superiorly it's the ilium, and then anteriorly it's the pelvis. So we're going to focus on that, and we're going to focus on the femur for now. In terms of the clinical anatomy and ligamentous support, there are 3 major ligaments that help to support the femoral head into the acetabulum or its articulation, right? And those are the iliofemoral ligament, the pubofemoral ligament, and the ischiofemoral ligament. So let me see if I can find all of those here. So we have the iliofemoral ligament here, which you guys all can see. We have the pubofemoral ligament, and I don't think we're going to see the ischiofemoral ligament on here, but it's okay. It has its own slide. So as we progress, and we really start thinking about the ligaments of the hip and their role, we know that the number one role of a ligament is to connect a bone to a bone. So in this particular case, these ligaments are going to be connecting the femur to the pelvis in some way, shape, or form, right? So far, so good. We also know that they create stability about a joint, right? So in this particular case, these ligaments are going to be creating stability about the coxofemoral joint or the hip joint, right? And we can see these 3 ligaments here in this image. And the reason we couldn't see the ischiofemoral ligament in the other image is because it's a posteriorly driven ligament. So we can see that it has an attachment to the ischium, hence its name, and then the femur, right? We can see here that this is going to have an attachment to the ilium and the pubis. The iliofemoral ligament, as the name implies, has an attachment to the ilium, and then to, guess what, the femur. And then last but not least would be our pubofemoral ligament, which has an attachment to the pubis anteriorly and then attaches to the femur. So if you think about this as a critical thinking component of this lecture, each of these ligaments has an attachment to the femur. That makes sense, right? But then each of these ligaments independently attach to each of the bones that make up the acetabulum. Are you guys tracking with me here? Like right now, are you having a aha moment, right? We said the ischium is comprised, or the acetabulum is comprised of which 3 bones? We said it's comprised of the pubic bone anteriorly. So we have the pubofemoral ligament, right? We said superiorly. Sorry, I got excited, guys. We said superiorly. We said that it is comprised of the ilium. So we have the iliofemoral ligament, right? And then posteriorly, what did we say? We said it was the ischium. So we have the ischiofemoral ligament here, you guys. So we have these 3 ligaments which attach to the 3 different bones that make up the acetabulum. And then all of those have a distal attachment to the femur. Who would have thought, right, you guys? So what we can say is that each of these ligaments provide stability, but they also connect a specific joint, the pubofemoral joint, the iliofemoral joint, or the ischiofemoral joint. I hope you guys got that. I got excited a little bit, okay? And hand away from the clicker from now on. Okay, so the iliofemoral ligament, you guys do need to know this. It is called the ligament of Y, and it's because it has a Y-shaped appearance, which we can certainly see in this image as we're looking at it. So here are the different bundles of the iliofemoral ligament, but it pretty much is known as the Y ligament. The cool thing about the iliofemoral ligament, okay, think about this, it's connecting the ilium to the femur, right? We know this. So if that's the case, we have to think about its anatomical alignment. Its major role is to prevent hyperextension of the hip, okay? Why do I talk about this ligament first? It's because it's the strongest of the 3 ligaments, and we'll see why in just a second, but it has to do with the way that its fibers are laying. What we can also see is that it's made up of 3 strong bands, right? So that should tell you something. Number 1, it prevents hyperextension of the hip. Number 2, what we know is it's the strongest of the 3 ligaments. If you're trying to think, well, how do I remember that it prevents hyperextension of the hip? It's an anteriorly positioned ligament, right? So just think, it wouldn't limit hip flexion. It's going to resist the motion opposite that. So it's going to limit hip hyperextension. Next, we have the pubofemoral ligament. The pubofemoral ligament is here. You guys can see it. It's going to attach the pubic bone to the femur. It is its responsibility, okay? So think about this. It's kind of a medial anterior ligament. So it's going to prevent massive amounts of abduction and also aid in preventing hip extension. But its major role is to prevent hip abduction. So when we go into abduction, the reason we're limited in our amount of abduction, you can kind of blame that on the hip adductor muscle group, but you can also blame that on the pubofemoral ligament as well. Our ischiofemoral ligament, as you can kind of see it here, right here, it's going to connect the ischium to the femur posteriorly. And you would, obviously you would assume that, oh, it's going to prevent hip flexion. But the reality is, one of the cool things about the ischiofemoral ligament is it wraps onto the anterior aspect of the femur. And so it also prevents hip hyperextension. The other thing that this ligament does that the other 2 do not is it actually helps to stabilize the head in the acetabulum. So it kind of is like a spiral muscle in essence. You can kind of see it ringing around. It's that ringing around or that spiral nature that tucks the femoral head into the acetabulum. So again, we can see how these 3 ligaments, all of them prevent hyperextension, right, of the hip. But then each of these ligaments do something unique and distinct, which is why they serve a function at the hip. It's these 3 ligaments that provide massive amounts of joint stability to the coxofemoral joint. The next anatomical structure that we'll spend a little bit of time with is the ligamentum teres. The ligamentum teres, as you guys can kind of see here and somewhat here, is a triangular band. Most often it's made up of 3 different bundles. And its major role, quite honestly, in the hip is to serve as a connection piece between the acetabulum and the femoral head. Most specifically, it has an attachment to the fovea of the femur, and then again has that attachment to the acetabulum. In terms of its role, there were some purported roles, such as like the ligament created some form of blood supply through an indirect arterial affiliation, but that has been debunked. So what they really typically say is that the role of the ligamentum teres is just to provide stability, in particular to provide stability in flexion adduction moments. So again, it's another stabilizing structure that doesn't really have much of a role. But what we know about the ligamentum teres is that it's most often injured, or can become injured most often in hip dislocations, in particular inferior hip dislocations of the coxofemoral joint. Our next stop is going to be the muscular anatomy, and I am not spending a whole bunch of time here because I feel like we have this down. But on the anterior aspect of the hip, we have the rectus femoris, which has a proximal attachment to the anterior inferior iliac spine. We have the sartorius, which has an attachment to the pelvis, right, and attaches to the anterior superior iliac spine. And then we have the iliopsoas group. I'm really going to refer to the psoas major, which has a proximal attachment starting at T12, right? And each of these muscles, if we think about what they do at the hip, they're going to serve to flex the hip, most certainly, I think, concentrically in terms of its contraction. Their major role as a group is hip flexion, but we certainly know that the sartorius does much more than that, right? It's a major hip abductor as well. So we can see, and an internal rotator of the hip. So we can see that ultimately the anterior compartment of the hip is going to serve or assist with hip flexion. The medial aspect of the hip is mainly comprised of the adductor muscle group and the gracilis. As a whole, they are concentrically going to contract to cause the hip to adduct. We also know that secondarily they aid in hip internal rotation. So you have this muscle group on the medial aspect of the limb working to adduct or to slow down the rate at which we abduct the hip. And here they are. You can kind of see them. I hope that you got to see them in gross anatomy, but I really love this image. I really like the way that it shows how unique and distinct each of the adductor muscles are. I think a lot of times as clinicians, we group them all together, which is completely okay. But noting where each of these muscles are going to attach on the femur and on the pelvis, as you can see that there, becomes extremely important in your rehab approach, right? If we have, let's say, an injury to the longus, right, the way that we lunge might look different than if we have an injury to the pectineus, right? So those are just things to think about now that you're in an advanced lower extremity course. Is okay, they're certainly a group, but then independently, where do they attach distally, right? Where do they attach distally, and how does that change my evaluation? How does that change my rehab? How does that change my treatment, right? Those are questions that you're asking yourself as you start to think about the adductor muscle group. On the lateral side of the hip, we have several muscles, which we'll kind of talk about. Those are highlighted in yellow for a reason, and we'll talk about them on another slide. But we have the glute medius, most certainly misspelled I. So we have the glute medius, which is deep to the glute max, and we'll talk about the role of the glute medius. But at the hip, we know it's a hip abductor, but it certainly does other things in the transverse plane. We have the tensor fascia lata, right, which distally becomes the IT band, and we talked about the IT band in the knee online lectures, but now what we're referring to is its most proximal muscular component, right, which is a major hip abductor. And then posteriorly, we have the glute max, which is a hip extender, and the hamstring muscle group, right? And we talked a little bit about the hamstring muscle group and manual muscle testing at the knee. They're knee flexors, but they are also hip extenders as well. So we'll test them differently in the next few weeks in our lab class. So the muscles that I skipped on the other page are now here. They are the 6 internal muscles of the hip. And I'm sure you had a fun time looking at these during gross anatomy, right? Probably the most difficult thing to look at. But let's get an appreciation for these muscles. So play golf or go on quaaludes. That's kind of how I remember them. P, play, is going to be piriformis, golf, gemellus superior, or obturator internus. The other G is going to be gemellus inferior, your obturatus externus, and your quadratus femoris. And these are kind of listed in the order in which they lie. So from most superficial to deep, right? So if we look at this here, we can see the piriformis right here, right? And then the next muscle that we would expect to see would be the gemellus superior. And so we'll, piriformis, superior gemellus, or gemellus superior, depending on who you ask. Your obturator internus is going to be next. The gemellus inferior right here. So we can kind of see that. And then your quadratus femoris, which is way deep, looks easy on this image. But as a whole, one of the things that we know about these intrinsics is that they're going to control hip internal rotation during gait. So they're going to slow the rate at which we internally rotate during gait. And that will become important because if we don't slow that rate, just think as we're moving from the swing phase and we're touching back down to contact phase, right? One of the concerns is we'll slam into internal rotation, maybe valgus moments or moments at the knee, and it could lead to injury. So these muscles play a major role in controlling internal rotation during gait, which is huge, right? Any injury to them, and we don't have control in internal rotation, which leads to changes up the kinetic chain. So the glute medius, remember that I said we would talk about the glute medius a little bit deeper, right? So what we know about the glute medius is it certainly is a hip abductor. There is no question about that. But as we dive deeper into the literature and dissection, what we can see with the glute medius in particular is that it has bundles. And so the first bundle is the anterior bundle, and we can see its fibrous orientation. So the anterior fibers, and then we have the posterior fibers. And we can see that their fibrous orientation is in the opposite direction of each other. So our anterior fibers, not only do they abduct the hip, but they are also responsible for causing hip flexion and internal rotation. Our posterior fibers then also hip abduct, but drive hip extension and external rotation. So you need to know that the glute medius is more than just a frontal plane mover, right? I just told you that it works in the sagittal plane and the transverse plane. So what am I saying? It's a multiplanar muscle whose major role is to certainly stabilize the pelvis on the femur, but it certainly does more than just abduct the hip, right? And again, if we're thinking about rehab, if we're thinking about treatment, if we're thinking about assessment, this changes the way that I assess glute meds, right? Not only do I manually muscle test in hip abduction, guys, but I'm also going to manually muscle test with the hip inflection and abduction or extension and abduction, right? So you can see how this changes what we do clinically when we're assessing a patient who walks in with a glute medius strain. It also changes our rehab, right? If we have a muscle strain of the anterior fibers of the glute medius, not only should we be working in the frontal plane, but we certainly should be doing sagittal plane exercises and transverse plane exercises, right? Because the glute med does all three, or works in all three planes of movement. Okay, so clinical anatomy, first and foremost, is the femoral triangle. And this is important because if we have a hip dislocation, it's one of the major reasons that a patient can lose their limb and it's a medical emergency. But we have the femoral triangle, and it's a triangle because it's formed by the inguinal ligament superiorly, it's formed by the sartorius laterally, and then the adductor longus medially. And within that femoral triangle are what we would call our van, right? So we have the femoral vein, we have the femoral artery, and then last but not least, we have the femoral nerve. It's also a site that we can certainly assess a pulse, but most importantly, when we think about the femoral triangle and its role, we're extremely worried when we have a patient take an anterior blow to the hip. We're worried about the integrity of our neurovascular system, right? And if we have a hip dislocation, we're certainly worried about the patient losing their actual hip, right? So the femoral triangle and knowing what it's made up of is extremely important. Next, we have bursae of the hip, just like we had in the knee joint. We know that the hip, remember, it's extremely stable, but certainly a mobile structure, right? And so we want to reduce friction wherever we can. So first and foremost, we have the trochanteric bursa. The trochanteric bursa, as you can see, is located over that greater trochanter at the distal site or attachment to the glute medius, because there's going to be friction and rubbing of that tendon when, but listen to me, when there's flexion extension moments, right? And so there's a bursa there, and that the role of the bursa, as you guys already know, is to reduce friction over a bone, right? So we have the trochanteric bursa, probably the one that's injured most often. We have the iliopsoas bursa, the ischiogluteal bursa, and then last but not least, the gluteus medius bursa. What am I saying to you guys? The one that's most common is going to be the trochanteric bursa. In terms of neurovascular anatomy, the first neurovascular structure that we really need to know and own is the femoral nerve. But you certainly we have branches off of that femoral nerve. Anteriorly, we have the obturator nerve, which is going to serve the adductor muscle group, right? So we have that obturator nerve, we have the femoral nerve, and then posteriorly, we have the sciatic nerve, right? The sciatic nerve is going to supply most of the posterior musculature. So again, the femoral nerve, the obturator nerve, and then you have the sciatic nerve. All of those become important in our lower quarter screen, right? Remember that L1 through S2 assessment of your patient's neurovascular integrity. As we progress, I think I haven't talked about vascular anatomy. So if I'm talking about it, then I'm hoping that you're understanding that this is actually an important component to hip pathology. So we have an array of vascular arteries that supply the femur and keep that bone alive. So the two that are most common are the medial femoral circumflex arteries and the lateral femoral circumflex arteries. But I think to me, the most important is this medial circumflex femoral artery. Its major role is to supply the femoral head. Are you listening to me? To supply the femoral head with blood flow so that the femoral head doesn't die. Now, I want you to put this in your back pocket so that when we get to injuries, we're going to talk about some where the femoral head starts to die because there's a lack of blood supply. And the major compromise is to that medial femoral circumflex artery, right? Okay, what we know about the neck, I guess, of the femur is that it's supplied by the lateral femoral circumflex artery. So a lot of times if we don't have healing after a femoral neck stress fracture, most often there's compromise to the lateral femoral circumflex arteries. And then we also have the obturator artery. I don't think it's pictured here, at least I'm not seeing it, but the obturator artery will create direct supply to the femoral head. So you have two blood supplies really aiding to serve that femoral head and supply it so it can stay rich in blood supply. And that's the medial femoral circumflex arteries and the obturator artery. Okay, so features of the joint. What's the primary function of the hip? Have you started asking yourself that? What do you think? Okay, so what we know about forces on the hip. So if we look at this, when is the force greatest about the hip? I think none of us would be surprised that most often running is going to increase the amount of forces going across the hip, right? And standing will have very little forces going through the hip. So you can look at this from a ascending perspective, starting with the lowest, going to the highest. But what do you think the function of the hip is? Okay, so if you said the following, to transfer force from the lower extremity to the spine, you would be correct, right? It is the midway point. You guys, are you guys excited yet? The hip and the pelvis represent the midway point. So we're now at a place where we're ready to take all of the forces that have been distributed through the lower extremity and transfer those to the spine so that they can then be transferred to the skull, right? So the hip's primary function is really force transference from the lower extremity to the spine. I don't know if that gets you excited, but I'm getting excited about that. Okay, so this is for you to use to study. And I'm not going to go through all of these because you have to own these, right? But let me just briefly walk you through this table. These are motions at the hip: flexion, hip abduction, hip internal rotation, hip extension, hip adduction, external rotation. And then these are all of the muscles that are driving that motion, right? So hint, hint, flashcard time, right? For my exam, but then also for the board of certification exam. And then I'll take it even deeper. For you to be good clinicians, you need to know what's driving hip flexion, right? This would be rectus femoris. This would be biceps femoris. I'm assuming you guys know this is glute max, glute med, right? These all become important for you to understand, because as you're manually muscle testing, as you're assessing for a strain of a muscle, you need to know which muscles are driving that particular movement. So maybe screenshot this and study it. Whatever would be helpful. I can tell you for our exam, you will be asked certain questions like which muscles drive hip abduction, and you should be able to say more than just glute med. This concludes this portion of the online lecture series. I'm actually thinking that I'm going to break it into 3 parts as I went through this lecture. So the next part of this series will be on the observation and inspection portion of the hip. Thank you for listening to this online lecture.